a lot going on. Students are busy studying, having clinicals in the morning. So let's go ahead and start. I'll start with a word of prayer and then we'll get started. So let's all bow our heads. Dear Heavenly Father, thank you so much, Lord, that we are able to take a few minutes out of our busy schedules to come together and have a good discussion about COVID and some questions that we are all experiencing and having. I ask that you be with every single student, faculty, staff, and Dr. Weinstein on this call. Guide and protect each and every single one of us, Lord. In Jesus' name, amen. All right. So I'm going to go ahead and record this. So in case, May, can you record for me? Thanks. In case some students aren't able to join us. Well, thank you everyone for joining us this evening. Dr. Weinstein, thank you so much for taking time out of your busy schedule to come and talk to our students and answer some questions that they have had on the COVID vaccine. And there may be some additional questions that you have as follow-ups to what he's going to talk about. If you go ahead and put that in the chat, we'll make sure that we can get to those questions at the end. So at this time, Dr. Weinstein, if you would please just take a few minutes to kind of give us a backstory of you, how long you've been in the network, and your background and so forth.
Oh, sure. Thank you. So I have been with Kettering Health Network for almost 25 years now, actually. I am an infectious disease specialist by my training, and I practiced infectious diseases at Kettering and throughout the network for almost 20 years. And then about 5.5 years ago, I was hired as the Chief Quality Officer for Kettering and Sycamore hospitals, and now I'm the Patient Safety Officer for the entire network. So as you can imagine, my areas of responsibility include infection prevention and control, so preventing hospital-acquired infections, what's called antimicrobial stewardship, where I work with pharmacy and we help make sure patients are on the right antibiotics, and we optimize our antibiotic usage. And then I'm also over some of the residency requirements, training the medical residents in terms of quality and safety. What we call our Candor program, which is a program where we are very open and honest to patients and families when there's been a harm event. And we work closely with the chaplains and with patient relations and others to reach out to the families and try to answer their questions and be open with them, as opposed to in the past, there was always a lot of sweeping things under the rug. But as you can imagine, for the last year, COVID has been really one of the top thing on my plate. I am helping to lead the network response to COVID in terms of policies, procedures. How do we do isolation? How do we handle patients and their families, our staff, and of course now vaccination of our staff, and now the community has become, front and center of our strategies around COVID. So that's kind of my background. And a lot of the work that I do every day is surrounding, policies, protocols, and other things around the vaccine. I don't know if any of you online, any of you on the call might have seen, but the network marketing featured me in a video that was specifically about the vaccination and its safety, because we did have concerns about some of the employees and how many of them were going to want to get vaccinated, how many of them were afraid. So there is a video where I explain some of what we'll be talking about here tonight as well.
Okay. Well, we'll get started with the first. Thank you so much for your background. That's why Dr. Weinstein is the expert to have come tonight to talk to us about this, much more than any knowledge that I can have on it. So we appreciate that. And one of the questions, thank you so much to those of you that sent your questions in. I have given Dr. Weinstein a heads up on the question. So what we'll do is I'll ask the first one, and if you want to just continue on, or we can go back and forth. The first one is, how well are the current vaccines responding to the new strands of COVID?
Yes, that's a great question. So it appears that the most common variant strain in the United States is what's called the UK strain that originated in England. And It's being found in many, many states. I don't think it's been found in Ohio yet, but we're not doing a lot of surveillance for it, unfortunately. But the vaccines, both of the two vaccines that are approved in the United States, appear to be very effective against that strain. Whereas there's a strain from South Africa where the vaccine appears to be only partially effective and not fully protective. So that means that the percentage of people who are protected is going to be lower, but still in those cases, let's say it's down to 70% effective or 50% effective. Those people who get infected, but they've received the vaccine, what we're seeing is they typically don't have a severe infection. So they've still gotten some partial protection against it. It's very similar to the flu vaccine. If you get a flu vaccine in the fall, it doesn't completely protect you from getting the flu, but if you get flu, it's likely to be less severe.
Very good. And then another question is, I realize we haven't been dealing with this for long, but what sort of long-term effects are being seen in people who contracted COVID and even had just a mild case?
Okay, very good question. About 40% of people who get infected with COVID don't have any symptoms at all. Now, those 40%, however, we know they can transmit the virus to other people, so they are contagious. And for the most part, they do not develop any long-term sequelae or any long-term health problems from having had the infection. But again, the real reason that it's a concern is that they can spread it to their loved ones, their parents, grandparents, contacts, anyone who might be more susceptible to getting sick from COVID. And then you've got, of course, the chain of transmission going on. For people who had symptoms, it pretty much is related to the severity of your symptoms. If you had very severe disease and were hospitalized and on oxygen, particularly if you had to go on a breathing machine or a ventilator, a lot of those patients have long-term symptoms, mainly surrounding respiratory problems. So shortness of breath, fatigue, weakness. What happens is actually their lungs develop fibrosis, basically scarring in their lungs, almost as if they had been a smoker, even if they never smoked. So that's why they can develop, persistent symptoms. There are other patients who develop what they call long haul symptoms, which is more like, more so fatigue and a little bit of shortness of breath. That can go on, as far as we know, for many months. We don't really, obviously COVID has only been seen in this country for about a year now. So we don't really know the long-term history of that. But clearly people who have COVID, some of them do have long-term consequences.
Okay, very good. What percentage of Americans need to be abiding by the mask mandates and getting the vaccine and able to allow us to return to normal anytime soon?
Well, there's varying estimates of that. I think on the low end, it's around 70, 75%. Others believe that we got to get above 80 to 90% for what's called, herd immunity. Now that can be a combination of people who have had COVID previously, along with those who are vaccinated. But it's important to know that we really don't know how long immunity lasts from natural infection. So let's say you had COVID 6 months ago. We've certainly seen, there's not a lot, but there are cases around the world of people who then got it again. And my understanding is that with the strain in South Africa, that there's quite a lot of people who get it twice. They had the initial strain and now they're getting the variant strain. The vaccination, especially given that you get a booster shot, is supposed to, or the idea behind it is that it gives much longer lasting immunity. So, if I get a tetanus shot, I'm protected against tetanus for 10 years before I need to get another booster. There are some vaccines that we give, like hepatitis A, hepatitis B. Typically, you never need to get any more boosters after you've had your vaccine series. It lasts the rest of your life. And then you have viruses like influenza, where the virus mutates very quickly. And every year there are new strains that are circulating around the world. And that's why they have to change the vaccine every year. And everyone has to get a vaccine every year. So we're not sure yet where COVID or this virus SARS-CoV-2 will end up. Is this it? Are we just going to get these 2 shots, or are we going to need another shot in 5 years or another shot in 2 years? We don't know that yet.
Only time will tell
Right.
with that
In
one.
terms of not wearing masks and getting back to, life as normal before COVID, I don't foresee that until probably late summer to fall, depending on what happens with the curve of the epidemic and how fast vaccination gets, how much penetration of the vaccine we have, and in what, period of time.
Okay, and to kind of go along with that, another question was, why are a lot of people getting sick after receiving the second dose of the vaccine? And then I thought that it was an mRNA vaccine, which would give us the code to fight the virus instead of infecting us with a small amount, which we would then build up antibodies to be like in the flu shot. Okay,
well, a couple things to unpack there. Actually, we're not seeing a lot of COVID infections after the second dose. What we're seeing after the second dose is higher rate of side effects from the vaccine itself. So after the first dose, almost everyone has pain in their arm for a day or two. A few people get more troubling symptoms like chills or low-grade fever. Some people get a little bit of a rash around the site of the where they got their vaccine. But for most people, the first shot is pretty easy. The second shot is where we're seeing more side effects. So people after the second shot are getting, again, pain in their arm, but they're not, and again, not everyone. A lot of people get their second shot and do just fine with it and have no issues. But a higher percentage of people get symptoms like chills, muscle aches, and fatigue and headache after the second shot. Occasionally they get a fever, but they don't get cough. They don't get infection with COVID. These are all side effects of the vaccine, not the infection. It's not COVID infection itself. Now, we have seen COVID infections that occur after the first shot. So let's say I got exposed to someone 7 days ago who had COVID, and now I'm incubating the infection myself, and I had my vaccine 2 days ago, and then tomorrow I start having a cough and fever and I get tested and I'm positive. That's because I got infected just before I got vaccinated, and of course, my immune system has not had enough time to react to the vaccine yet. What we do know is that after you've had your second dose, after about 10 to 14 days after your second dose, your risk of getting infected is cut by about 95%. So you could still get infected, but your risk of getting infected is much, much, much lower than it was before you got your vaccine series.
Okay, thank you. And then we have a question in the chat, but it actually is one that was asked too, I recently had COVID. I was told I should still get the vaccination. What is the difference between a vaccination and the actual disease that makes for proper immunity?
Well, the only difference really is duration. So if you've had COVID infection itself, we know that you probably have 3 to 6 months of immunity, at least from the same strain of getting reinfected again. And that's why if you've had COVID, it's okay to put off the vaccine for, they're saying 90 days. But they're also, CDC's official, the official CDC recommendation on this is if you've had COVID infection and you are now recovered, you can get vaccinated at any time. If you had COVID a month ago and now you're fully recovered, you can get the vaccine today. Or if you choose, you can wait for 90 days. And the reason for that is that you're still protected for those 90 days. And the other reason is that some people who had COVID and then get their first shot have more severe side effects of the vaccine. So to me, this is like, I had more side effects with my second dose because my immune system was primed. Well, if you had COVID, naturally occurring disease, and then let's say a month later you get your first shot, well, your immune system was primed by the infection that you had, and you can have more side effects of the vaccine. It's important to know, though, that true serious side effects of the vaccine are very, very rare. there are very rare cases of anaphylaxis where you have a severe reaction where you have trouble breathing and all that. Very rare. And those have all occurred in people who have had previous anaphylaxis to other medications and vaccines. In fact, they were in people who carry EpiPens with them. So short of that, most everyone else is having side effects that are maybe unpleasant, but they're not life-threatening at all.
Okay, very good, because that, by answering the 90-day, that answered the chat one and then one of our other questions. So
Yeah,
thank
I saw
you
the one
for
in the
that.
chat. Right, I saw the one in the chat, and I know at first there was a little bit of conflicting information on that. We did put out a communication from Incident Command about it about a week ago, where we said that basically you have two options. You can go ahead and get the vaccine as soon as you're recovered and you're not in your quarantine anymore, or if you choose, you can wait 90 days.
Okay. I have a question. What is the percentage of, because our students are doing clinicals in our network hospitals, what is the percentage right now of our employees within the network that have all started at least their first round of the vaccine?
Great question. It's not as high as we would have liked. We're at around 55%, but that's the total number of our employees. So that includes people who do not see patients at all. So the percentage of people who, let's say, work in finance, or they work in the kitchen, or they work on grounds and maintenance, who did not get their vaccine is higher. I'm sorry, who did not is higher. Among the people like nurses and doctors, it's much higher. And I know that among physicians, it's over 80% did get their vaccine. I'm not sure the exact number for nurses, but it's certainly higher than the 55%. And this is pretty close to what has been seen nationwide.
Oh, well, that's good to know that we are right in the curve with it. Is there any other questions you guys have for Dr. Weinstein? He is our expert and he is here to answer our questions tonight.
Emmanuel had his hand raised. So Emmanuel, go ahead and unmute yourself and ask the question. You can also turn on your camera too, so we can see who you are.
Thank you so much, and thank you, Dr. Weinstein. I've been following along, and you did point out that the tetanus shot gives you immunity to, let's say, a given period of time. Are there any studies so far indicating for how long someone that gets the shot will perhaps have immunity longer for, or we keep on getting boosters for these kinds of for the virus?
Right.
Also,
yeah.
Also, the other question: once we get to there's so many strains, and they need to return to normal, does that mean that with every new strain, we'll be having to, develop a new vaccine, then get revaccinated, and get the booster again for that new strain before we can resume to normal?
These are very good questions to which I can only give you partial answers. Because this is all relatively new, we don't really know, for example, we don't know how long the immunity will last from the vaccine. We know that immunity from natural infection seems to last probably in the 6 to 9 month range. With the vaccine, the antibody levels tend to be higher and they tend to be more persistent than after you've had naturally acquired disease. So it is felt that with vaccination, you will have longer lasting immunity. Now, in terms of your question about the variant strains as they come along, will we need to get a new vaccine or more boosters? I don't know. It's possible, but no one really knows the answer to that yet. What I can tell you is that the companies that make these vaccines are already beginning to make new batches of vaccine that are based on some of these variant strains, so that if it seems that the variant strains get out of control and they're infecting people who already got vaccinated with the current vaccine, they'll be able to, hopefully pretty rapidly produce a new vaccine that would be effective against these newer strains. Kind of like the flu. I mean, like I said, every year we get a new flu vaccine, and every year we have to or it's highly recommended. For healthcare workers, it's mandatory to get your flu vaccine every year.
And another question is, will we have to be vaccinated again in 6 months?
Yeah, we don't know the answer to that. Hopefully not 6 months. It's possible it would be a year. It's possible it would be 2 years. It's possible we will not need to be vaccinated again at all. Don't know the answer. I wish I could tell you. I do see an important question here about the concern about infertility as a long-term effect of vaccination. That was a myth that got propagated across the internet, and there is no truth to that at all. So that one can be put to rest.
Dr. DeLang, you had a question. If you want to unmute and also turn on your video camera.
All right. I've got a problem with my video camera. It says it's
Hi, Paul. How are you?
happened to me this morning, the same exact thing. So sorry, I can't get that up. It's
That's
really
okay.
me.
I know Paul, and I know his pretty face.
There you go. Dr. Weinstein, I'm really baffled by a lot of what we're hearing about this disease in terms of the general principles of immunology. It doesn't seem like it follows them. That's the frank question. We say that you're infected with this, your immunity only lasts 6 to 9 months. Well, what we teach all the time is you're initially infected, you develop typically the IgM, it's short-lived, but then you have a secondary response when you're exposed, rapid, high levels, IgG, long-lasting immunity. Why are we saying with this one, you have such short immunity and then you're really vulnerable again? What happened to secondary response? And why does it seem that we're treating this so differently? And then I have a follow-up question after that one.
Yeah. So actually, yes, you're exactly right. But the reason is similar to the flu vaccine, is because the virus is mutating. I think if the virus does not change, then we probably would not need to certainly get a booster in 6 months or a year. And you look at things like tetanus. Of course, tetanus is a bacterial disease that has a protein toxin. And that tetanus toxin has not changed in millennia. But we still need a booster every 10 years because our immunity does wane through time. And your antibody levels are just not, through many years, your antibody levels can go down. And again, with this virus, let's say there's no mutation at all. Probably this vaccine would give us, years of protection. I don't know how long. But it's the mutations that are really leading to the concerns about how long. And like I said, in the people who've been infected twice, they've by and large been infected by the initial strain, and then they get a variant strain later. And their immune system is primed to mainly the spike protein on the surface of the virus. And what happens is that spike protein changes enough that our antibody response that was generated no longer can neutralize the virus.
Right. Okay. And I think the difference, which I've tried to communicate often too, between something like tetanus and pertussis, for example, is that I don't make it a habit to go around and expose myself to that toxin with tetanus. So my immunity wanes naturally. Whereas with pertussis, I'm being exposed naturally all of the time. I would assume the same thing would be happening with coronavirus. If the virus is here for the foreseeable future and forever, and so it seems to me that we would be exposed aside from the mutation of the spike. That's obviously a separate issue altogether. Let me ask another question that has baffled me also a little bit. This is a disease that right now has, I guess, contrary to what we hear so much, the mortality rate itself is really quite low. And yet we are really going out of our way for vaccination program, masks, and devastation of the economy. And yet you keep coming back to it over and over and over again. This disease is not killing large numbers of people, and the people it is are largely in a very select age group. Why so much attention? We now have gone from, we want to lower the curve, to now we don't even want anybody to get the disease. Why
Yeah.
such emphasis on a disease that we have not done this with in the past?
Well, a couple of answers to that. I'll try to give a couple of answers to it. And I will say, as you were mentioning a minute ago, this is, I can't begin to predict what this virus is going to do. Right now, the rates of COVID across Ohio are going way, way down. And it's too early for this to be related to this vaccination campaign because we're only at about 8 or 9% of the state having gotten their first dose. It's just really hard to predict the behavior of this virus. In the past, when there have been similar viruses that caused epidemics, the SARS epidemic and then the MERS epidemic, those viruses vanished from the face of the earth and they've never come back. Whereas this virus, mainly because of the numbers of people, we're in the, I don't even remember now how many, millions and millions of, I think 100 million or more infections worldwide and like 40 million or something in the United States. This virus is so prevalent that the feeling is that it's going to maintain itself and not die out. But getting to your question there, it just depends on your perspective. I mean, this virus has a mortality rate of close to 2%. Influenza, which we vaccinate against every year, has a mortality rate of about 0.2%. So this virus is probably about almost 10 times as deadly as influenza. Maybe not quite that much. Maybe it's 4 or 5 times as deadly. And it is true that most, but the rate of mortality though, if you look at anyone over 80 years old, you're getting up to mortality rates of 20, 30%. And if you look at the numbers across the state and the country, half of all people who have died from this virus are 80 years old or above. Now that's half of them. Some of them are in their 70s, some are in their 60s. And then of course, we've had people in their 50s and 40s and even 30s or younger who have died from the virus, not as many. And then you have people like young athletes who might get myocarditis and could have arrhythmias and other problems from the infection that could maybe they didn't die directly from the pneumonia from the virus, but they could get sick or die from other aspects of the virus. So that's part of it. It is a, relatively to many other infections, it is a high mortality rate. So, you look in the United States and we're at over 400,000 people died of a disease that we never knew. We'd never heard of this disease a year and a half ago. And now it's the second or first leading cause of death in the United States. So it really is a big thing. And it really is a common cause of death in the country. And then the other part of the answer I would give is that when the virus gets to epidemic levels in a community, it overwhelms our healthcare system. And you've seen parts of the country where hospitals were treating patients in parking lots and garages and, gift shops. And then people who have a heart attack or a stroke, or they've got cancer and need to have surgery, they can't get their treatments. So that's the other reason is it's a huge strain on the healthcare system in the United States. In Ohio, we were lucky, we never quite got there. But we did get up to where over 25% of all the patients in our hospitals were COVID patients. And again, that's a disease that we never heard of a year and 3 months ago. And to have 25% of our patients in the hospital all with that one disease, it is a huge strain on the system.
Thanks. Appreciate it, Dr. Weinstein.
Oh, you're welcome.
And
Emily.
do you still have a question?
I do. I can start video if you really want it. But it's nighttime in this house. So with
Hi.
right after the vaccine came out, the American Society of Reproductive Medicine, ACOG, all of them were pretty quick to say everyone should get vaccinated who can. Why, do you have any insight as to why the World Health Organization has been so strange with their comments about it and kind of withholding that recommendation?
It's a great question. I can tell you that with COVID treatments, the World Health Organization takes a much different stance than the CDC does, in part because of many countries around the world don't have the resources financially or logistically to treat people with certain medications like remdesivir that are intravenous and things like that. In terms of the vaccine for pregnant women, obviously there's a lot of issues around liability. There's unknown issues, obviously, with with the developing fetus. The current stance in the United States is that it's not recommended to get vaccinated during the first trimester, but during second and third trimester, it is a decision between the individual and her physician. So, pregnant women were not specifically included in the clinical trials, but there were a few who slipped in, and generally they did fine. And there's no known birth defects. The vaccines were tested in laboratory animals, and I don't believe that they saw any major birth defects in pregnant, rodents and things like that. But, we always take an abundance of precaution when we're dealing with a pregnant woman. And so I guess the WHO just has been more cautious than other groups. We've definitely had pregnant women sick enough to be hospitalized with COVID-19. And luckily they did fine. But prevention is certainly better than getting infected, but it's an individual decision right now because we don't know, we don't know the long term with pregnant women and their babies.
Thank you.
More so with the babies than with the moms
Right.
themselves. Yeah. Great question.
And then Emmanuel has another question.
I promise this is gonna be the last one. So I don't know if you spoke about it, but we've seen, I've read stories of people that have had the infection, or they had, let's say, one strain, and they got remedy, like they were treated with some kind of medication, and actually they cured. Now, I also do understand that given the various strains that really are coming up with the mutation rate of the vaccine, of the virus, it's so hard to really come up with a cure for this outbreak. So are there any studies that have actually been focused on aiming at, let's say, arriving at the cure other than digging more into vaccination?
Yeah, so there have been, lots of different medications have been studied. Most of the studies have been a little bit underwhelming in terms of the medication, being effective. And part of the reason is because most of the time, people who have COVID are not very sick at the beginning, and it's about a week into their illness that they get sick enough to be hospitalized or go to the doctor. And what we know now is that you're already getting to the edge of when it's too late to treat. Treatment needs to be given very early. And we know that there are certain treatments that are effective, especially if given in the first 7 to 10 days of infection. So one of the most important medications is steroids. And steroids that are given early to people who are sick enough to be in the hospital and on oxygen do help reduce the mortality rate. And that's a good thing because steroids are available worldwide, and oral steroids are very inexpensive. There are other medications that are aimed directly at fighting the virus. And the main one that's called remdesivir that I mentioned earlier, in vitro, so in the test tube, it works great against the virus. The problem is that most people, by the time they get treated, they're beyond the phase of illness where the virus is actively replicating in their lungs and in their body, and they're onto what's called the inflammatory phase of disease, where it's your own body's immune system causing inflammation in your lungs and other organs that is doing the damage, and that's why steroids help. But there are some other medications too, and we also have been using plasma. So plasma contains antibodies from people who already had COVID, and if given early, that is effective. And then there's also now what we call monoclonal antibodies. These are antibodies that are developed in the lab and essentially manufactured that can be given to people, again, if they have early phase disease with COVID-19. What we know is that these antibodies can help prevent disease progression and they help prevent people from needing to be hospitalized with the infection. So there are some treatments that are effective against the virus, and then there are others that have been tested and proved not to be effective. But most of the ones that are effective have to be given very early during the infection.
Thank you so much. Thank you.
You're welcome.
Is there anyone else that has a question?
Yes, I have a follow-up. This is Paul DeLang again. On the treatment, we all heard a lot of conflicting results early about hydroxychloroquine. Has that been firmly established? Is that still being researched? What's the state of it? I know we have all kinds of it available. Is there any more attempt to revisit its effectiveness in treatment?
Probably there are some studies still ongoing, but multiple, so there's a variety of different medications that were tested, and many of them were tested in non-scientific fashion, meaning they were just given to everyone and there was no randomization, there was no formal, trial. And the studies, although they ended up doing some randomized trials with hydroxychloroquine and it failed, it did not improve mortality rates. It did not lead to faster resolution of symptoms compared to placebo. Same thing with azithromycin. And early on in the pandemic, people were combining those two medications together, and they have an interaction where they can cause cardiac arrhythmias. So, those two pretty much were dropped from the treatment regimen pretty early. However, in the community, we have people still prescribing those drugs, even though the CDC, the National Institute of Health, and the Infectious Disease Society of America says do not prescribe these drugs. They do not work for COVID. There are still people out there prescribing them. Then there are other drugs like that may or may not help, but we don't have good proof. And those are things like vitamin D and zinc. A lot of people have been using those. They're probably not harmful, but we don't have any evidence right now that they're actually beneficial for patients with COVID-19.
Okay, thanks.
There's a couple other medications. There's one called baricitinib, which is it's called a JAK inhibitor, usually used for blood disorders, and that does seem to have a benefit, especially when combined with remdesivir. There's another one that's called tocilizumab that's used for autoimmune disorders that seems to have a benefit in severely ill patients with COVID-19. But some of these medications are extremely expensive and in short supply. So it's been a real challenge getting medications that really work against this virus.
Okay, we have another question in the chat about, I have read a lot about people having clots months after having COVID. Are you seeing this?
Well, I'm not sure about months after, but definitely during their COVID infection and for at least weeks afterwards, COVID does seem to cause a hypercoagulable state. And so we've seen people come in with both venous and arterial blood clots. So that means like a DVT in the leg or pulmonary embolism, and those are venous clots. Or we've seen people come in with stroke, which is an arterial blood clot, and potentially even myocardial infarction, which would be an arterial blood clot. So there's no question that there is a procoagulant effect of the infection. And in fact, there are trials that are going on, and we're enrolling in one, of giving people who have had COVID blood thinners for several months after their infection to see if we can prevent them in the period after their acute infection with COVID. That's a good question. And then I see the question about ivermectin. Ivermectin has gotten some press, and it's controversial. The bottom line with ivermectin is there are no well-designed clinical trials yet that have proven that it's beneficial for COVID-19. There are some small non-randomized trials that suggested it might be beneficial, but it is not recommended for use outside of a clinical trial, at least in the United States. It's a anti-parasitic drug that's usually used for things like, well, we use it for scabies in the United States. We use it for strongyloidiasis in the United States, and it's used for river blindness in Africa. And it actually helped, by giving mass treatments of ivermectin, it helped get rid of the epidemic of blindness in some African countries that occurred. But it's not proven to be effective against COVID, at least not yet.
All right.
Yeah, I mean, from Brazil, I'd like to see a randomized controlled trial that was done in a good fashion, because the NIH and the IDSA clearly state, you can go to the website, go to the NIH guidelines or the IDS guidelines, and they explain why those studies were not well done and do not prove whether ivermectin is beneficial for COVID. It's a readily available drug. If it were beneficial, we would be giving it.
Well, thank you so much, Dr. Weinstein. We truly